All right. Well, today we're going to talk about peripartum depression and some of the newer treatment options that are available. And so today we're going to touch on three main treatment options. We're going to talk about zuranolone as well as TMS and ketamine. And so, why is this important, especially as an OBGYN, to be aware of? So, unfortunately, as you know, I'm sure the maternal mortality rate in the United States is very, very high, much higher than any other developed nation. And unfortunately, mental health conditions are actually the leading cause of maternal mortality, and pretty significantly so based on this data from the CDC that's a couple years old, compared to other common complications like things like hemorrhage and infection. And just as a reminder, I know Dr. Boonder did a great talk on PMADs not too long ago, but just a quick refresher so we know what we're dealing with. Perinatal mood and anxiety disorders, specifically depression, affects about 1 in 5 birthing people, which is about 15 to 20% of folks. And in addition to being the leading cause of maternal mortality, PMADs are actually the most common complication of pregnancy overall. And suicide and overdose are the leading causes of death within the first year postpartum. And PMADs actually have their highest prevalence between 2 and 6 months postpartum, which is a little bit later than some of our other complications, and unfortunately occurs after that routine 6 week postpartum visit, which makes it even more challenging to identify some of these folks. And unfortunately, up to 80% of birthing people with PMADs are not ever diagnosed or treated. So, how do we define perinatal depression? So, in psychiatry, we use the DSM 5 as kind of our guiding book for diagnosing different conditions. And there is no term for postpartum depression or perinatal depression in the DSM. Rather, we have major depressive disorder, which is the same whether or not we're talking about it in or outside of the perinatal period, with the specifier with peripartum onset. And so basically, all this means is that we're looking for the symptoms of major depressive disorder, which are things like depressed mood or anhedonia, sleep or appetite changes, psychomotor changes, difficulty focusing, and even suicidal thoughts. And so, in order to meet this diagnosis per the DSM definition, you have to have at least 5 of these symptoms, one of which is either depressed mood or anhedonia. These symptoms have to occur for a majority of the time for at least a 2 week stretch, and they do have to cause clinically significant impairment in some aspect of functioning. And so, if we're purely going by the DSM, this is how we would define perinatal depression. Although, if you recall from a slide or two back, the highest incidence of depression actually does occur between 2 and 6 months postpartum. So, this particular definition is really limiting and honestly excludes a large number of women with perinatal depression. So, I think a better definition is actually the following slide. This is kind of what I go by in my practice. So we're looking for those same symptoms that are listed in the DSM, but we're looking for symptom onset either during pregnancy or within that entire first year postpartum. And a lot of the symptoms of depression can be difficult to tease apart in someone who's just had a baby. And so we're looking for symptoms that are out of proportion to what would be expected in a new mother. For example, asking about sleep changes in a new mom. I think nearly all new moms are going to have sleep changes or sleep deprivation. And so rather than just asking about how much sleep are you getting, maybe kind of asking, are you able to sleep when you get the chance to sleep, when baby's taken care of? Or, appetite changes. We would expect someone who's breastfeeding to experience an increase in appetite. And so perhaps if someone who is breastfeeding reports a decreased appetite, that could potentially be a red flag for depression and may warrant further evaluation. And just as a reminder, perinatal depression is highly, highly comorbid with anxiety symptoms. And particularly, we see a lot of intrusive thoughts. And just as a reminder, intrusive thoughts are those unwanted, distressing thoughts or images that pop into the patient's head. In this population, they're frequently related to thoughts of harm happening either to baby or to the patient themselves, and they produce quite a bit of anxiety. Perinatal depression can certainly impair with mom's ability to bond with baby. And things that I hear frequently are things like feeling like a bad mom or not feeling cut out for the job. Lots of kind of negative thoughts about the self. And it's important to be able to differentiate what is perinatal depression versus what is postpartum or baby blues. And so the baby blues is a really common phenomenon that occurs in about 85% of new mothers. The symptoms usually start pretty soon after delivery, within about 10 days. Fortunately, the baby blues are typically short-lived and resolve completely within about 2 weeks. And in contrast to some of those symptoms we saw with depression, the baby blues are really characterized by a lot of mood lability or mood swings, irritability, lots of crying, tearfulness, fatigue. And the working theory is that these symptoms are really related to that large drop in hormones at the time of delivery, as well as that acute sleep deprivation that occurs soon after delivery. And so, because of that, it's fortunate that the baby blues responds really well to sleep and social support interventions. And one thing I just wanted to mention is that regardless of the timing or the duration, if someone is reporting more severe symptoms like feelings of hopelessness or suicide, or the symptoms are making it impossible to care for themselves or care for the baby, that is always concerning for perinatal depression, rather than the baby blues. And so, kind of moving into some of the newer treatment options. This is just a figure showing some changes in hormone levels that occur throughout pregnancy and up to the time of delivery. And the two hormones I just wanted to point out are particularly estradiol in blue and progesterone in green. And so all of these hormones, but those in particular, take a really precipitous drop right at the time of delivery after they've reached pretty high levels near the end of pregnancy. And so, kind of the working theory for why postpartum depression develops is not necessarily the fact that there is a change in these hormone levels, because that happens to everyone who has a baby, but it appears that there's a subgroup of women that are really sensitive to that large shift in estrogen and progesterone levels. And we see these same changes that tend to occur surrounding the menstrual cycle and perimenopause as well. And we think it's mostly related to some downstream effects from stress-related steroids. And the one that we're going to focus on today is a steroid that is a breakdown product of progesterone. And so I know this is kind of a busy slide, but really what we're thinking about is um, progesterone, as I mentioned, drops off precipitously at the time of delivery. Progesterone is normally broken down into a neuroactive steroid called allopregnanolone. And allopregnanolone has actions at GABA A receptors. And GABA receptors are inhibitory, they're calming, they are the receptors that things like benzodiazepines and alcohol acts on. And so allopregnanolone binds at a site other than the active site, which is what we mean when we say a positive allosteric modulator. And at the end of the day, the outcome of this is we think it turns down the hypothalamic pituitary adrenal axis, or really the stress response. We're kind of turning down that stress response by having allopregnanolone act on these GABA receptors. And it's been found that lower levels of allopregnanolone and having that poor allopregnanolone response to stress during pregnancy is actually associated with the later development of postpartum depression. And so I know that is a mouthful to talk about. And the reason this is important is that's really the mechanism for the development of our treatment of brexanolone and zuranolone. And so brexanolone was our first FDA approved treatment for postpartum depression, which was an IV infusion over 60 hours and required admission to the hospital. Back in 2023, the FDA approved zuranolone, the oral formulation for treatment of postpartum depression. And so I just included this figure from the phase 3 trials for zuranolone. And really, I think the notable things to look at are that zuranolone was only taken for 14 days. And you can see on this graph that there was actually a significant reduction in depressive symptoms by day 3. So that means that the effects were really rapid, which is really significant when we compare that to our traditional antidepressants that can take weeks or months to fully take effect. And we may have to adjust the dose over time. So kicks in really quickly. Had statistically significant reductions in depressive symptoms at the end of that 14-day course of medication, and the results were sustained through the end of the study, which was 45 days. We don't know much beyond that 45-day mark, but that still is really promising to have that information. And so a little bit more about zuranolone. So the trade name for zuranolone is Zurzuvae. And like I said, it's an oral formulation. And so really what it is an analog of allopregnanolone, that neuroactive steroid that acts at those GABA A receptors. And so as I mentioned, this was FDA approved back in August of 2023 for postpartum depression. And the dose is 50 milligrams once daily in the evening for 14 days. And zuranolone only comes in 20, 25, or 30 milligram capsules. So it's going to be two of those 25 milligram capsules once daily. It's important to know that zuranolone is a Schedule 4 controlled substance, and patients must take this with food. And the manufacturer specifically recommends taking a high-fat meal to improve absorption. And they recommended, at a minimum, eating 400 calories with about minimum 25% fat content. So, if you were to prescribe zuranolone to someone, what are the potential side effects? So, by and large, the biggest side effect is sedation or somnolence. Because of this, we tell our patients to take the medication in the evening, typically with dinner before bedtime, and it's recommended to avoid driving for 12 hours after that dose. So, if they take it at, say, 7 p.m., they shouldn't drive until 7 a.m. the next day. We want to be really mindful about combining zuranolone with any other CNS depressants, things like benzodiazepines, alcohol, opioids, because we don't want to cause oversedation or potentially have some catastrophic outcome by doing so. And if sedation or somnolence occurs, the manufacturer recommends reducing the dose back to 40 milligrams daily to see if that helps, or if it's just not tolerable, simply stopping the medication. Other fairly common side effects are things like dizziness, headache, or nausea. And there has been some note of possible associations with increased suicidal thoughts. Fortunately, in this population, our patients are generally pretty healthy, but if you were to have somebody with severe hepatic or renal impairment, we want to reduce the dose down to 30 milligrams daily. Okay, so if this is something that you're interested in, I kind of wrote out the steps for how to prescribe it. So if you feel like you have somebody that might be a candidate for zuranolone, step number one, you've got to diagnose them with postpartum depression. And most of the insurance companies are going to require that that particular episode of depression started either during the third trimester or within 4 weeks of delivery. I'm not a huge fan of this particular definition because it excludes a lot of women, but this is kind of what we have to go by for now. Zuranolone is not carried at traditional retail pharmacies, so this is not a prescription that you can just send down the street to Walgreens. This has to go to specific specialty pharmacies depending on the patient's insurance carrier. I'd say by and large, I have mostly encountered Accredo as the specialty pharmacy, but Sage actually kind of listed out which pharmacy is associated with which payer, which is really helpful, and I've included that on the slide. So as I mentioned, the dose is 50 milligrams daily for 14 days. The next step that's going to come up is this going to automatically trigger a prior authorization. And I highly, highly recommend doing the prior authorization because without it, I think it costs about $15,000 if you were to pay cash. So it's not required to prescribe the medication that the patient must have failed an SSRI or another antidepressant. That is not standard or required in most cases. I have encountered some insurance companies do ask for previous trials of antidepressants, and the specific insurance provider might require that. So that does come up from time to time. The ICD-10 code that you'll need to include is F53.0, which is just the code for postpartum depression. And from that point, the specialty pharmacy, once they get that prior auth approved, they will call the patient and work to ship the medication to the patient's home. Other kind of things to think about is if somebody's, say, already taking an antidepressant or they were recently also started on an antidepressant, they can continue taking that while taking zuranolone, so no need to stop or change that. Breastfeeding comes up a lot, so we have limited data on the use of zuranolone in breastfeeding, but the data that we do have is pretty reassuring. It appears to be transferred in very low amounts into the breast milk, and so we talk about this with our patients and kind of have the conversation of how much risk do you feel comfortable with? And by and large, we recommend continuing to breastfeed as long as mom is comfortable with it and kind of understands the limited data. And otherwise, this is not a medication that we can use during pregnancy, and it was not studied in bipolar disorder, so we don't use it in those folks either. And I know I mentioned the cost barriers with zuranolone, and fortunately, all of the companies I've encountered in South Carolina have covered the cost fully when approved, but Sage does also have a financial assistance program to hopefully help any patients that may not have insurance coverage or need some extra help affording the medication. And so lastly, this is just a figure from Sage, the manufacturer. They gave a couple scenarios about patients who might be good candidates for zuranolone. So they mentioned someone who may be experiencing depressive symptoms for the first time after having a baby. Certainly could be a good candidate, as well as someone who maybe previously took an antidepressant medication but is having new symptoms. And so maybe that would be a situation where you have a conversation. Oh, you took Prozac in the past and it worked really well for you. Would you like to try going back on Prozac since we know it works? Would we like to try zuranolone? Maybe a combination approach. All of that would be appropriate. And the last scenario they listed was a mom who's maybe experiencing postpartum depression symptoms while they're taking an antidepressant. So maybe we've been working to maximize the dose of an antidepressant and the symptoms are just not remitting and we need some extra help. Certainly somebody that we could still consider starting zuranolone in. And then I think we were going to break for a minute before we switch over to Amy's presentation on Spravato and TMS.